So my name's Kelly Guillo. I live in Fayetteville, Georgia, right outside of Atlanta. I have a husband and four children, ranging in ages from 20 to 14. The youngest of my children is Clementine. She is 14 and she has Prader-Willi syndrome. I belong to the Georgia chapter of the Prader-Willi Syndrome Association. And I also founded a fundraising organization, a grassroots fundraising organization that raises money for Prader-Willi research, specifically at the University of Florida, because I would say the world's leading authority on Prader-Willi syndrome is there at the University of Florida. Prader-Willi syndrome is a rare disease. Its occurrence is estimated to be between 15,000 to 25,000 people, one person born between 15,000 and 25,000 people annually. It does not discriminate amongst genders or racial lines. It originates from three different causes. My daughter's case, she was born with Prader-Willi syndrome by uniparental disomy. So the long and short of that is when she was conceived, two of my 15th chromosomes stuck together. My husband contributed his. It would have been a trisomy condition, which would have been incompatible with life. So there was something called a chromosomal rescue that occurred in her conception, and my husband's 15th chromosome was shed. So my daughter has both of my 15th chromosome. This results in her having Prader-Willi syndrome. It's a rarer, I guess, rarer subtype of the syndrome. The most common is a partial deletion on the father's contributing 15th chromosome, but the syndrome is basically the same regardless of the cause. It is a far-reaching global syndrome. It causes developmental delays, global delays, poor metabolism, hypotonia, which is low muscle tone. There are risks for obesity and obesity-related health problems, and that is a result of the most hallmark symptom of Prader-Willi syndrome, which is hyperphagia. Hyperphagia is basically defined as a hunger that is unable to be satiated. So people, when they are in the hyperphagic stage of Prader-Willi syndrome, will never feel full. They will always feel not just hungry, but starving. And it's a legitimate hunger signal. At some point during the development of people with PWS, and the age varies, but it happens to everyone who has the syndrome, the brain will start to malfunction. The hypothalamus starts to send out the hunger signal. And once it goes out, it continues to stay on and it never shuts down. So, as you might imagine, this is a very difficult aspect of the syndrome, and requires constant management and vigilance and supervision. People with PWS cannot be left unattended, or they will literally eat themselves to death. I personally know of one family in our area whose son passed away. I think he was in his early 20s. He went to a Braves baseball game and he had a caregiver, but he was a very high functioning individual and said to the caregiver, "Hey, I'm going to go to the bathroom." And he did go to the bathroom, but then he also went to one of the vending areas in the stadium. And he had a bunch of money that he had saved in his pocket, which the caregiver was unaware of. He ate so much food that later that day, of course, he was taken to the hospital, his stomach perforated, and he died. These are not uncommon stories. These are not exaggerations. These are things that happen with some frequency in our community. So Prader-Willi syndrome, it's a very unique, very challenging, very difficult syndrome for the individual that's affected, but also for caregivers and families alike. It's very challenging. You know, I can speak from my experience. What you said is 100% my lived experience. When Clementine was diagnosed, it wasn't given to us right away what the cause of her PWS was. We weren't sure if it was a deletion or a UPD or an extremely rare occurrence called an imprinting defect, which is inheritable, hardly, very rare. Come to find out a couple of days later, actually probably more like a week later, that she was a UPD, which means that it was my contribution to her that caused her to have PWS. And it is not logical to feel responsible. It is not logical to blame yourself, but it is the very first thing that I did. The very first thing that I did. And in my case, I'm an older mom. So I thought, not only is it my fault because of the type of occurrence, but it's also my fault because it happened because I'm an older mother. The likelihood is greater when you're an older mother. It can happen when you're younger, but most of the time it's for older mothers who have, two 15th chromosomes that stuck together, which the risk goes up as you're older. So I blame myself in both of those areas. And I was lucky to have a couple of doctors who were compassionate, and I voiced that concern. I think a lot of people may keep that inside, but I actually voiced that concern and I had that conversation and, of course, was told, no, that's absolutely not the case. You could never have known this. This is a random situation, et cetera, et cetera. But you do feel that guilt. And I, honestly, I might still carry some of that with me. I do think about that from time to time. We all know that, we all share some of the same feelings and emotions. And what I want to encourage people to do, what I try to encourage people to do so much is to not isolate themselves and to know that they are part of a much bigger community, not just a PWS community, but a rare disease community, a developmental disability community. There's a million different ways to slice it. You're not alone. You're never alone. And on your worst day and the worst things that could have happened to you because of your child's condition or syndrome, you have to know that other people have experienced the same thing. And I believe that with all of my heart. We all have such commonality amongst us. This is actually, if ever there was a good time to be born with Prader-Willi syndrome, it is now. There has not been a treatment approved by the FDA since growth hormone was approved around the year 2000. Since then, there have been, I would say, at least to my knowledge, probably 10 other trials of different medications, almost all of them focusing on hyperphagia and the hyperphagic part of the syndrome. Most of them have failed. In some cases, they've run out of money. In a couple of cases, there were some adverse events that shut down the trials. But at this moment now, there is one trial that is awaiting its PDUFA date, which is March 28th of this year, for a medication that has gone through 3 stages and has shown very good results in the reduction of hyperphagia. So the first really ever to show promising results that have been sustainable. And so we're keeping our fingers crossed that the FDA will approve this drug. But in addition to that, there are at least 3 others. Again, all of them are focusing on hyperphagia, but what we've seen in trials is that if the hyperphagia can be moderated, because I don't really believe that it can be eliminated, it's more a question of moderation, then we see a lot of the other challenging symptoms of the syndrome, things like anxiety, behavioral issues, hostility, aggressive outbursts, all of those things also decline. So if you affect the hyperphagia, you affect the whole individual and most of the most challenging parts of PWS. So we are very hopeful. We're very hopeful with research.
Yeah.
That's the tricky part because there's no biomarker, there's no clinical, there's no assessment that can be done that can be measured specifically. So there is a hyperphagia questionnaire that was developed by some people at Vanderbilt some years back, and it is in use now as the only real determination of success of any medication. And so most of the information comes from the caregiver answering questions and comparing those answers over time. Sometimes the information can come from the affected individual if they are able to communicate well enough answers to those questions. But just recently, this is very interesting, just recently, as a result of the fundraising that my group did, there has been a goal attainment scaling tool developed. It's called the James Henson Jr. Goal Inventory for Prader-Willi Syndrome. Has just been developed and it's going through its vetting process. And right now they're looking for some trials that could potentially use it. And it will measure things other than hyperphagia, and it will rely more on the individual that's affected than the parent and caregiver to determine what is successful and what is not. I can't claim to be an expert on the subject, but I just listened to a webinar about it and it's very exciting. And we are hopeful. You know, we've been given reason to think that perhaps this time will be successful because without it, you know, there really aren't many other successful tools other than a lock and key. And that's just not the quality of life anyone wants for their loved ones.